Thanks. Now I'd like to start by thanking the AAAPC and SAPC for being here. It's a great honour, and it is my first time to SAPC as well. I'm going to be talking about the development of a novel colorectal cancer risk prediction tool that we're doing in Australia, and I'll start with a little bit of background and context. So Australia and New Zealand have the highest rate of colorectal cancer globally, and age standardised rates show that men are slightly higher than women. We know that screening asymptomatic patients increases early detection, and early detection reduces incidence and mortality. The Australian guidelines currently recommend screening based on age and family history of colorectal cancer. The Australian government have developed a national bowel cancer screening program where we send an FOBT kit, which is a fecal occult blood test kit, to all Australians from the age of 50. So when you turn 50, you get one of these. Nonetheless, there's quite a low participation rate. Only 36% of people actually send it back. Conversely, there's this mismatch between the use of colonoscopy for screening and individual risk of colorectal cancer. For every million Australians 50 years and over, 80,000 people who are at average risk of colorectal cancer are having unnecessary colonoscopies, whereas 29,000 people at increased risk of colorectal cancer are not having colonoscopies. So the government has actually supported a 5-year program of research called the Centre for Research Excellence, optimising screening for colorectal cancer. And this is the team of chief investigators, one of whom at least is here, who've been brought together to actually sort of try and work on this problem. It's a really interesting group of people, and all speaking kind of slightly different languages. And we have mathematical modellers, we have clinicians and gastroenterologists and GPs, we have involvement from the government, geneticists, epidemiologists, cancer researchers, IT experts, and of course at the top, the most important, the primary care researchers, all working together for the same aims. So the overall aims of the CRE are to increase risk-appropriate screening for bowel cancer by developing an Australian colorectal cancer risk prediction model. And this model is actually called the CRISP risk model. You can see here it's about working out which variables are to include and then how to actually sort of put it together. The second aim is to increase risk-appropriate screening by developing a risk tool that will actually house the model. And confusingly, the tool is also called CRISP. And then actually implementing this tool into general practice primary care. So today I'm going to talk about the primary care research component within this CRE, and I'll just talk briefly about the program of research. So we're following this is led by Professor John Emery, who's in the audience. We're following the Medical Research Council guidelines for developing and evaluating complex interventions in primary care. And we've mapped out our sort of program of research, looking at basically going from finding the evidence for building a prototype tool to then looking at how it actually might be used in general practice to actually lead into trials and then long-term implementation. So I'm going to talk about the preclinical phase just quickly. This is still kind of giving you a bit of the context. Building the evidence for CRISP. We did a systematic review of cancer risk assessment tools in primary care, and we found that there weren't a huge amount of tools, but we used this to sort of devise some methods and looking at ways to actually sort of increase our optimised tool. We hadn't developed the model at this stage when we started developing the tool because the two things are being developed in parallel. So we used the work by Wynne, who's one of our people in the CRE, who did a systematic review on risk prediction models, and from that we chose to use the Friedman model. The tool was designed to be flexible so that once the CRISP model is developed, it will actually incorporate different variables or different questions if need be. So you can see this model included age, BMI, vegetable intake, exercise, medication including non-steroidal anti-inflammatories and HRT, smoking, colorectal cancer screening, and family history. So phase 1. So in phase 1, we worked on actually designing and developing an optimal CRISP tool. determining the usability and acceptability of this prototype tool in general practice, and looking at implementation strategies that might help us get it into practice. For our study participants, we didn't just want to ask GPs what they thought of it. We went for a sort of a whole clinic approach. So we included GPs, practice nurses and practice managers. And we did per post of sampling to make sure that we had a pretty good range of clinics and staff. We did this really fun thing using simulated consultations. We had professional actors who are used to playing medical patients, and we took them to general practice clinics of GPs that signed up, and in the actual consultation room, the GPs did a consultation with the patient, knowing that they were an actor, and then used the tool throughout the consultation. We videoed this, and the GPs had a little bit of a play around with the tool beforehand so that it wasn't just completely cold. For the practice nurses and practice managers, we demonstrated the tool to them, and then we did interviewing with them all afterwards. This is just a screenshot of a doctor and a patient using the tool. I want to put some video in, but we haven't really got time. So we did semi-structured interviews after the GP had the consultation, or after the practice nurse and practice manager had been demonstrated the tool. And again, this is around usability, acceptability and implementation. The analysis. We transcribed all the interviews, and we also looked very closely at the video footage and included in our data set non-verbal things that were actually should be included that were quite important to the way that the GP used the tool particularly. The data were managed in Deduce, which is an online qualitative data management system. Where possible, where the GPs, practice nurses and practice managers from the same clinic, we looked for consensus between the three groups. And then we did a lot of sort of roundtable discussion between the authors of this to actually sort of have a look at what the themes were. And once we had our themes, we then mapped them onto normalisation process theory, which is a model for implementing, embedding and sustaining interventions in clinical care, which I think you would have heard about already from other people. So we developed this prototype and called it CRISP, Colorectal Cancer Risk Prediction. We had the collecting of the variables, and then at the end of that we had to put in clinical recommendations, and these were based on the risk output. Average risk people were recommended to have, if they were under 50, they would be recommended to have no screening, but if they were 50 and over, they would have recommended to have a fecal occult blood test. Otherwise, if they were at increased risk, to have a colonoscopy, and otherwise, if they were at considerable potentially increased risk, we would refer them for family cancer clinic analysis. So the risk presentation, there's a lot of literature about how best to predict risk, and this is just to make sure you're still awake. I am from Australia, but this is actually in South Africa. So how do we best sort of let people know what their risk is? Multiple forms of risk are usually the best way to present from what we understand. So we had absolute risk statements, what their absolute risk would be at 5, 10 and 20 years, and we used an icon array to display this as well. We also used a graph where we had a look at the risk compared to the background population over time. And these are the results of who we had. I won't go too much into this. Suffice to say that we had 14 GPs, 9 practice nurses and 6 practice managers, and we had a pretty good range of samples, so that was good. So I'm going to explain our results in the context of NPT, and there are 4 constructs within NPT. So the first one we looked at was coherence. Did the actual clinic staff make sense and understand CRISP in the context of what they do? We found that clinicians understood the rationale behind CRISP. They said, yep, they completely get it, they really understand it. They often used risk prediction tools, particularly for things like diabetes, cardiovascular disease and depression. And interestingly, a quote from a practice manager, she said, look, we often use risk assessment tools in the practice and we find them valuable. So from that point of view, we're not unfamiliar with using them and wouldn't be averse to using them across the board. So the other clinic staff were aware of risk assessment tools as well. So the second construct is looking at cognitive participation. So it's one thing to understand an intervention and say that's really, we get what you're doing and we understand why you're doing it. But do they actually engage with this intervention and do they buy into it? That's sort of the next level. One thing we found that GPs really engaged with and found very sort of instinctive was when they were asking questions about lifestyle, particularly smoking and what exercise they did and intake. They would really sort of they liked that sort of way that it sort of naturally segued into that, and they could ask the question in a very sort of easy way. But they also did this very sort of instinctive thing where, do you smoke? No. And they would say, good, that's really good. Or, oh, look, we'll talk about that later, and then make a note to follow up with that. So it gave them opportunity to really engage with the patient in that GP way. Some of them found the screening recommendations quite challenging though. So when the screening recommendation came up at the end and it was different from what they had anticipated, the GP had anticipated, then they disconnected a bit from using the tool. And GPs often said colonoscopy is the gold standard and balked at the idea of an average risk patient just having an FOBT. Collective action. So we looked at the action, and this is really how, what's the capacity for including this within existing clinical systems? And we also included this relationship between the patient and the GP as well. So that system that exists as well. So the first thing was, it was very obvious, if a GP was very comfortable with computers, then they could actually use it a lot more seamlessly and a lot more easily. So what I defined as computer agility was a bit of an implementation barrier. And I'm just going to show you a bit of a still. So this is very often how the GP started talking to the patient. Note the piece of paper and the pen too, which is really interesting. And then very often when it came to actually looking at the tool, they did this. And you can see straight away, I think that's pretty clear that that sort of disconnect happens. And that happened quite often. But with younger GPs who really touch type, they could often sort of do the seamless thing a lot more easily. One of the constructs of general practice, which we hear about all the time, is of course consultation time, and that's a major implementation barrier, including one more thing. There was a general consensus within the clinic, and this is why it was really good to include practice nurses and practice managers in this. A lot of people really felt that practice nurses have greater capacity to use the CRISP tool, and in Australia we have a 45 to 49-year-old checkup, and a lot of people mentioned, will it be an optimum time to sort of preempt the National Bowel Cancer Screening Program. There was a little bit of a fear of missing a cancer diagnosis and a little bit of a fear on the GP's behalf of relinquishing the responsibility for actually making the final clinical decision though. So those sort of collective or clinic issues would need to be sort of addressed. The final sort of construct is looking at reflexive monitoring. How do they monitor, evaluate and appraise an intervention over time? So the clinic could understand it, engage with it, think it's really fantastic and find a place for it to work within the clinic. But then what happens over time? As so many interventions we know just sort of don't stick. And they all said, great idea, but we just don't have the time, usually. They have the capacity, but very often there's sort of just not much sort of interaction between the clinicians and everybody because everyone's so busy. There's very much a sort of problem of the month that somebody will say, hey, we haven't looked at our diabetes rate, so diabetes becomes the sort of problem of the month that they deal with. So that's another implementation barrier. On the basis of our results, the tool was modified and we've developed CRISP version 2. Fewer screens, very important, more intuitive, fewer buttons to click, and also an ability to navigate backwards and forwards within the tool. Originally, you'd have to just go through the tool and then one of the GPs would want to say, let's see what happens if you stop smoking, and you go back and you lose all the data. We're also investigating how we might actually auto-populate the tool from the patient records or also actually populate the risk that we actually collect back into the patient record. And we're also exploring other, the risk formats as well. But what we've done is optimise the tool. We had initially a very long, complicated, multiple-page way of collecting family history to this lovely, simple format, which we've tested with the GPs, and it's very intuitive and easy to use. The icon array scale, we changed from 100 people to 1,000. People had a lot of trouble interpreting what this kind of, what do you say about that? A person who has 75% of a person, so this was a better array. We also changed the scale of the graph because this is actually a 20, only goes up to 20, so people found this quite alarming, not surprisingly. I mean, this isn't the same risk here, but you can just see the scale makes it all a little bit flatter. So that was one thing that we changed as well. So we found that CRIST is acceptable. We found sort of a preferred model of implementation involving practice nurses. And we've actually designed a much more optimised tool to increase the usability. Things that we found that were consistent with the literature too was that adding a bit of a health promotion helped with the implementation, as well as having a dedicated clinician, and that's in the form of the practice nurse. So what's next that I can come and talk about next year? We've actually started a phase 2, very small randomised controlled trial to test the feasibility of the methods and to collect some preliminary data. And I thought I'd just show you a photo of some of our team in Melbourne, and this is in our new building. So if you come over to visit us after the 27th of July, this is where we're going to be. It looks very nice. This is Victorian Comprehensive Cancer Centre. And I'd just like to thank people too, like Fiona Walter and Elizabeth Murray, who were very involved in it as well. Thank you.